Yes.
Good afternoon, everyone. I am Dr. Gaurav Khera. I'm a senior consultant orthopedics, and I'm doing spine surgeries and joint replacement surgeries at Apollo Spectra Hospital at Karol Bagh, New Delhi. So today, what we are talking about is understanding endoscopic spine surgery. Now, as you know, that keyhole surgeries are the new big thing in all surgical fields. Similarly, endoscopic spine surgery has really come up very big as far as spine surgeries are concerned. Now, before I talk about what is endoscopic spine surgery, I would want to first explain to you what a disc is. Now, in our body, we have the spine can be divided into first is your cervical spine, that is your neck. Second is your dorsal spine, that is in the chest. Finally, we have the lower five, that is the lumbar spine, that is the lower back. Then we have the sacrum and the coccyx. Now, these spine, the bones, the bodies, they're arranged one on top of the other like a bamboo stick. So, what happens is that when we would walk, we would run, these separate segments would hit each other, and ultimately, because of the compression, there would be a lot of wear and tear. So, nature has given us discs which act as shock absorbers between these bones. So, the basic function of a disc is to act as a shock absorber. Now, if you look at this model over here, we have the brain over here, and there's a tunnel which goes right through your spine, and through this passes the cord. And at every level, this cord gives off these nerve roots, then which further go down either to your legs, to your hand, to your chest, abdomen, and they form the main nerves, which are called the spinal nerves. Now, this disc is present somewhere like this, and this disc has an outer fibrous layer and an inner pulpous layer. If you take an aloe vera plant and you cut the leaf, that is exactly how a disc looks from inside. The outside is thick, fibrous, and inside is pulp. You can actually press it and you can feel the pulp. So, when now, for example, let's say a patient has a fall, or the patient has bad posture, or the patient does certain activities where the disc gets compressed and again and again, this outer fibrous layer tends to degenerate, it tears, and this pulp from inside it comes out and it starts to press on the cord or the nerve root. And that is what we commonly call disc herniation. आप लोग जब ओपीडी में आके बोलते हैं कि हमको डिस्क का प्रॉब्लम है, this is actually what is happening with you. Now, when do I plan to operate? Back pain is not a cause for spine surgery. So, it's not necessary that if you're coming to me with back pain, I'm going to say you have to get operated. We will operate for leg pain. Why? Because leg pain is happening because this nerve is getting compressed and the nerve is misfiring and the pain is coming down into your leg. So the patient comes to me, I'll put the patient on certain medication, I'll put the patient on physiotherapy. If the patient is not responding, the leg pain is increasing, or there is weakness in the leg, or there is bowel bladder involvement. For example, the patient says that I cannot control my bladder movements or I cannot control my bowel movements. These are the cases when we decide to operate. So I will first ask for an MRI. The MRI will give me the clear picture that which disc is involved, which nerve is getting compressed, and how much compression is there. That is where endoscopic spine surgery comes into play. Now, endoscopic spine surgery, this can be done in two ways. One is directly from behind, I make a tunnel, and this tunnel, I make a small hole in the bone, and with that, with my microscope, I and my camera, I see this cord, I push it to one side, and I remove the disc. Sorry. This is called distendo technique. Now, what I am commonly doing is called a transforaminal endoscopic spine surgery. This is the latest thing which has come. So here we do not touch the bone at all. So far lateral, almost close to the flank, I take the patient to the OT. We mark out, we make the patient lie ulta, okay, that is prone. And once the patient is lying like that, then we mark out the different levels of the spine. We mark out our entry point with the help of a machine called a C-arm. And I put a small tube inside and I put my camera inside. And that tube goes directly all the way here, right till the disc. And we'll bypass all these bony structures, we'll bypass the cord, and we'll bypass the nerve root, and we go right here where the disc is. And with the camera, I'm actually seeing the disc, I'm seeing where I am. and I cut out this outer fibrous part and I remove this entire inside pulp. Now, there are multiple advantages of this. First, it is an extremely non invasive procedure where I'm not touching the nerve root, I'm not touching the bone. Post operative pain is very less. Second, this procedure can be done under local anesthesia. So there are a lot of patients who have anesthesia related complications or are not fit for anesthesia. This procedure is fantastic for them. So in such cases, I do it under local. The patient is awake. The patient is talking to me. Third, there is immediate relief. On the OT table, the patient tells me that my back pain, my leg pain has improved, and the patient can get discharged the same day. So this is uh, this is the advantage that we have over the conventional method. Conventionally, what we used to do is that we used to cut out a piece of the bone, we would remove the entire disc, and then we would keep the patient resting till the time everything would not heal. Now, um, what what all do I expect from a patient and what all do I check in a patient when the patient comes to me? I will first examine the power of the limb. I will see that what is the strength, whether the limbs if there's any weakness. We do the grading of the power. I will see the reflexes. I will see how the nerves are responding, and we chart all this out. Now this is compared with your post-operative score, and we see we are looking for an improvement. I normally do not get an MRI done after the surgery because the patient is symptomatically fine unless and until post-operative there is some problem. We normally do not get a MRI repeated. Now we come to the complications. Complications, of course, are very less. As I said, that it is a very safe procedure. One of the complications is that the patient may not get a complete um, relief in pain. The patient may sometimes continue to complain of pain. This can happen in cases where the disc is long standing. So what happens in a long standing disc is that these discs they tend to dehydrate. Now when they dehydrate, this joint, the disc space, this is reduced, and there's a lot of spondylitic changes that start coming. And spondylitic changes means that there is new bone formation that starts happening. When there is new bone formation, there is a lot of arthritic change which is coming in the facet also. These are the facets. Facets are where the two bones are meeting each other. Now, when all this starts to happen, I do not expect too much of relief in the pain. So, these are the kind of patients who don't respond very well to this procedure. Secondly, if the patient has got associated too much of stenosis, so this canal through which my cord is going, now you imagine a tunnel and you have cars going through this tunnel. Now it's four-lane highway on one side and four-lane on the other side. You have a beautiful eight-lane highway, and you've got all these cars going in a very streamlined way. Suddenly, you reduce the size of the tunnel to half. What will happen? Cars will start hitting each other, and then there'll be a traffic jam. So that is what happens in stenosis. This entire canal it gets stenosed. So when there is some bony cause of stenosis or the ligament is hypertrophied, in those cases, a simple disectomy is not very effective, and we may have to plan for an open procedure or at least a MR, different form of MRI surgery where I will have to remove some part of the bone. Uh, I think that this is it as far as what the surgery is all about is concerned. Now, as patients, what you need to look for is when you have back pain is first is are you having any leg pain associated with it? Are you having any weakness in your limbs associated with it? Are you having any bladder symptoms associated with it? And in case you're having all of these, of course, you should get in touch with the spine surgeon immediately. I really suggest that you all should avoid going for massage therapies and all if you're having back pains. Avoid going to quacks. There are a lot of quacks which are practicing. A lot of patients go to quacks, and when they can be handled in an earlier stage, they actually worsen the situation, and then they come to us. Now, what are the causes of disc is also something I would want to tell you. First is your lifestyle, your posture. We tend to slouch when we sit on a chair. You should be sitting upright. You should always get up when you have a long sitting hour. You should get up every 1.5 hours, walk around for some time, sit again. Back exercises are very important. You should do all spinal back exercises, extension, flexion exercises. Weight is another issue. Excess of weight causes a lot of stress on the lower back muscles, which tends to again keep the spine in a pulled up condition, and that can lead to these problems. And other lifestyle issues like smoking and drinking, this is also a common problem. Now, I believe this is a live session. If any of you have any questions, I would be willing to answer the questions. And I think I have spoken about the surgery now, and I would be hoping that you all share your questions with me. So, thanks a lot.
Sir, I have some questions. Is chiropractic recommended?
Is chiropractic.
Chiropractic
Yeah.
recommended?
See, once you have a now chiropractors, what they do is that they claim that they realign the spine and everything. But once you have a disc prolapse, I do not recommend chiropractic. I always suggest that it's better that you go into a proper physiotherapist, undergo proper rehabilitation, learn proper spinal extension exercises, and that would be a safer approach than going for chiropractic for a prolapsed disc.
So second question is, what are common spine problems?
So, common spine problems, one we've already spoken about today, is the disc prolapse. This can again be divided into disc bulge, disc prolapse, or disc extrusion. Disc bulge is when it's just the beginning, where this is not torn and it just starts to bulge out, it just starts to hit the cord or the nerve root. Then, extruded disc is when the entire thing comes out, and that's also prolapsed disc. Other common problems that we see are spondylitic changes. So as this degeneration, now the bone it starts to grow as spicules all around. This again starts to irritate the surrounding nerves, the surrounding muscles, and that can cause problems. Other common problems that we see commonly is stenosis. As I already told you, that the canal through which the nerve root is going that shortens out. That is called stenosis. Then you can have arthropathies, like you have arthritis in the knee joint. Similarly, you can have arthritis in these facet joints. For this, we're doing a lovely procedure over here in Apollo. Patients who have isolated back pains, I do what is called an RF ablation procedure, where with the help of a RF probe or a laser, we just burn out this joint, and that causes reduction in the pain. So these are the very common problems that we see daily in our day-to-day OPDs.
Thank you so much, sir. And what are the post effect of endoscopy surgeries?
Okay, so post endoscopic surgeries, a few common effects, and of course, there is some amount of post-operative pain that is there for about 2 to 3 days. The patient may complain of some amount of muscle stiffness. Over a period of time, when we get an MRI done, because we have removed the disc material, the disc space will tend to become less and it gets replaced by some amount of fibrous tissues. Other than this, there is no serious problem that the patient tends to face.
Okay, sir. Is it common in young people as well?
Yes, it is very common in young people. In fact, I am doing endoscopic disectomies more for younger people as compared to the older people. It's again, as I said, bad posture, long driving hours, being on a bike for a long time, going to the gym, and it's not being with an untrained trainer. and your posture is not correct while exercising. So I'm getting a lot of young patients with these problems these days.
And how can we diagnose this?
It can be diagnosed with an MRI. MRI is the gold standard for diagnosis. Till the time an MRI is not done, I cannot say that the person has a disc issue or not. But clinically, the patient will be presenting with back pain, which is coming down to the leg, and the pain increases when the patient starts to walk. That's called neurological claudication. That is one of the symptoms which we can see. But of course, MRI is the gold standard to diagnose a disc problem.
Thank you, sir. And sir, what is tesica, which pill and spine nephropathy? 1 minute. And what are the difference between them?
You'll have to show me the spelling. Okay. What is sciatica, whiplash injury, and spinal myelopathies? Now, sciatica is a symptom. All this, what I spoke about, that when you have back pain and the nerve root is getting compressed and the pain is coming down into the legs, that is called sciatica. Commonly, people say, "मेरे को sciatica का problem है, दर्द पूरे पैर में आता है." That is because there is some cause because of which the nerve root either is getting stretched or it is getting compressed, and this is causing pain to radiate down into the leg. This is sciatica. Whiplash is an injury that we see commonly in road traffic accidents. So these days, of course, we have to wear a seat belt because that's very important. Now, when there is a sudden deceleration, you're wearing a seat belt, your head will move forward and it moves back. So this is like a whip. So this can cause an injury to your neck. This is called a whiplash injury. It can be very severe and it can have very severe complications also. But it is very different from sciatica. And the last term that he told me was myelopathy. So when this spinal compression because of a disc or any other reason is not treated over a period of time, whether it is in the cervical spine, dorsal spine, lumbar spine, there is a change that starts to occur. It's a physical change that you can actually see on the MRI also that starts to occur in the cord. This is called a myelopathic change. This change can be permanent. Once myelopathy starts to set in, even after the surgery, even after removing the compression, a lot of times the patient does not come back to normal. So, ideally, getting myelopathy is not a good sign.
So, what is the success rate of endoscopic spine surgery, and how is it different or better from open surgery?
Okay. So success rate is it's almost a 90% successful surgery. Of course, patient selection is what is more important over here. Every patient is not an ideal candidate for an endoscopic spine surgery. Long-standing discs, multiple level discs, dehydrated discs should not be performed when there's too much of spondylosis, too much of ligament thickening, or bony changes. It should not be performed. The biggest advantage over an open conventional open surgery is, first, there is no scar. It is done under local anesthesia. There is no bony component which I'm cutting through. It is extremely safe. The chances of a damage happening to a nerve is very less, and my patient walks the very same day. In fact, the very my patient can walk out of the OT. It is that safe. So the advantages are innumerable over a normal open spine surgery.
So, my last question is how is Apollo Spectra tube to tackle any kind of orthopedic problems?
Apollo Spectra, I've been practicing with Apollo Spectra since 2015, and I'm very happy with the center. My patients are also very happy with the center. There's another center I operate in, which is definitely it's a bigger center, but my patients are actually more happy coming over here. They get personalized care. We have all the equipment. We have fully functional, fully equipped OTs over here. We have all the endoscopic equipment which is there, camera, light source. We've got good screens. We've got a lovely rehabilitation department, and especially my anesthesia department. We've got very senior anesthetists who are professionally even more senior than I am, and our nursing and other staff is they're fabulous. They take care of my patients as if they are their family members. So I am always very happy bringing my patients to Apollo Spectra and operating them over here.
Take home message.
So the take-home message today, what I would tell you is, of course, it is never a good thing to get a spine problem. To prevent a spine problem, leave habits like smoking, drinking, get your weight under control, do regular exercises, keep your posture proper. If you do gymming, you should always go to a good trainer. You should follow the advice of a professionally trained trainer. Keep your posture correct in the gym. And if you are having back pain, you should always seek medical help. It may be very simple, but it should always be looked at. And of course, if there is leg pain, then there is no doubt you should come for a medical advice. Thank you.
Thank you so much, sir.
Welcome.
Thanks
Thank
for your
you.
time.
Thank you for this opportunity. Thank you.